Dr. Maggie
That day I turn it on.
Tetrokalashvili, and her specialty is gynecology. Dr. Tetrokalashvili is Director of Gynecological Services at Hofstra University Medical Center. And we're privileged to have Dr. Tetrokalashvili with us. She has an extensive background, and we're very interested in what she has to say. Thank you.
Thank you so much. I just want to mention that it is very unusual to hear my name pronounced so correctly. And thank you so much for that effort. Good afternoon, everybody. As it was mentioned, I'm in charge of GYN, but also I have training, subspecialty training in infertility. So I do a lot of infertility at the Nassau Medical Center.
Just move on.
I shouldn't wear heels. When Rachel saw that she couldn't bear children for Jacob, she became envious of her sister Sarah, and she came to her and said, actually she came to Jacob and said, "Give me children or else I die." So infertility, as you see, is as old as civilization, and pain from it is also timeless. Next slide. If we look at the definition of infertility by WHO, it says that reproductive health is not merely the absence of the disease, but also the freedom of access to care, fertility care, contraceptive care, its ability to have children. So if we go by the definition, infertility clearly is a disease. And it's not only has medical implications, but also very profound psychological, economic, and demographic implications. If we look at the statistics, 5.3 million Americans, or 9% of reproductive age population, suffer from infertility. And in 2002 was the recent survey, National Survey of Family Growth. And it mentioned that 7.3 million American women aged 15 to 44, which is the reproductive age women, have impaired fecundity. Although you see the percentage of women that have infertility, not everybody has the access to the care. And out of those who actually go to the fertility specialist, 66% end up just getting an advice and never continuing with the diagnostic evaluation or the treatment. So you see the big discrepancy in the percentage in terms of seeking advice and actually how many people are actually getting the treatment for it. However, the number of ART or assisted reproductive technology cycles performed in the United States more than doubled. You see the numbers. And the good news is that the number of live births also increased from ART cycles. And today it is estimated that approximately 1% of US population is born with the assistance of reproductive technology. The prevalence, if you look at the prevalence is the number of infertile couples divided by the number of women who are at risk for pregnancy. So if we look what's happening over the years at this graph, if you look from 1965 to 2002 when the recent data is available, you might think that the infertility is increasing, right? Infertility is decreasing and fertility is better. But what happened in these different years, they involved women who had the tubal ligation as well. And the tubal ligation actually increased, almost doubled from 1965 to 1988. So we exclude women with tubal ligation who purposefully tied their tubes, and that's why they're infertile. Actually, the percentage of infertility will stay stable throughout the years, and it's approximately 13%. We probably see, or we have, we hear more about infertility, even though the rate is stable, because of generation of baby boomers. Also because of decreased availability of babies adopted overseas. Also, there is less stigma of infertility, so there are more people that are open, talking about the problems, and they're actually more seeking for help. And also the number of physicians who are able to help increased in the United States. We all know that as women we go through our career choices and many times delay the childbearing. So this is another reason why also we see more infertility, especially in American population and highly educated women. So it's about 10-15% of married couples in the United States are infertile. We all know that it's not only a medical problem, but how much stress often it places on the family. Usually patients feel guilt if they think that, okay, I'm the one who has infertility. Sometimes they even offer their partner to exit the marriage. So it's a tremendous emotional impact on the family, wanting children and not being able to have children. And especially cost. If you see the cost of the cycle, the one IVF cycle, average cost is about $12,000. I'm not even talking about the surrogate cycle. You see the numbers there. As a word of mouth, I want to spread, because I'm at Nassau Medical Center and I take care of the underprivileged sometimes population. We have some discounts in terms of the fertility cycles available for that population. So it's not completely hopeless. So there is a variation in numbers. Also, some of the insurances, they cover let's say a few cycles of IVF, or some of the insurances put certain amount of money towards the infertility treatment. So don't think that this number is very discouraging, because there are, for example, grants and certain pathways to decrease the costs and increase the access to the fertility care. When we're talking about the discrepancy, especially today, you see the discrepancy in the access of fertility care in terms of ethnicity. And you'll notice the non-Hispanic black population versus white population. There is a difference in access to fertility care, unfortunately. There are some specific definitions about what is fertility, what's primary, what's secondary, which means somebody who never had children or somebody had children and now infertile. I just want to mention that the only time we can say that person is sterile, sterility, if there are two factors. One is fallopian tubes are closed, and the second, if there is no sperm at all. Okay? Everything else is a question, has association with infertility, but it's not a proven cause of the infertility. So sterility only if the tubes are closed and there is no sperm. As I mentioned, it is a disease, and we say we have an arbitrary definition. How long the person is supposed to wait until we say, okay, this couple is infertile. And that definition is usually 12 months. Okay, and why is it 12 months? If we look at this table, what's the monthly probability of pregnancy? So it's about 20% for the couple who has absolutely no problem per month, the chance to get pregnant. So if the couple waits for a year, the chance is going to be up to 80-90%. In 2 years, it's close to 97%. There is not a big difference between 1 year and 2 years, and that's why we say, okay, let's wait a year, and if it's, if there is a problem, it's always good to seek an advice from the physician. But the good news also is that if, we wait, most of the couples that wait for 2 years, most of them actually will get pregnant. So there is a lot of reassurance also. When the couples come, oh, I tried for 3 months and nothing is happening, most of the time we're reassured that you need to wait a little bit longer. It is not true in every case, because as we know that when age goes up, then fertility goes down. So if somebody is older than 35, you don't want to send them away for 2 years. Right. Or if we know that there is some problem, right? Somebody comes instead of every month period, they have period every 6 months, we know it is a problem. Or they had testing with another physician and they know that maybe male factor or some uterine tubal disease. Those people, of course, you want to see immediately and not postpone, not to send them away. Okay. Very important, I always counsel couples. Usually I see females, but I always encourage them to bring the male partner with them. Because surprisingly, 40% of infertility is a combined male and female. Okay. And also important how you counsel the patients. Many times they come, they try, but they really don't know what's the best time to try. They don't know whether they should be using lubricants or don't use lubricants. So a lot of time is devoted actually for the education. And again, extensive history is important. I'm not going to go through all these definitions, but everything from childhood to menstrual history to medications to diseases, it's very important to get a thorough history from the couple. At this slide, I always say the joke, and I hope that male are not offended, but I say, why does it take 1 million sperm to fertilize 1 egg? Well, because they won't ask for directions either, right? If we're talking about the male partner, always important to ask if they have bumps or undescended testicles. So those are the clues can lead to maybe there is a male problem as well. And again, we go through the whole system, starting from the head and going down, including hypothalamus, pituitary, everything is important. Eating habits, right? Are these people overweight, or they actually supermodels, right? With anorexia nervosa, everything affects the menstrual cycle, affects the pelvis, history of contraception. There is some misperception about IUDs that I see among women. Say, okay, if I put an IUD, I might be infertile, I might get infection or pelvic inflammatory disease, which is not quite true. If there is no infection, IUD itself does not cause infection, right? But if there is IUD and there is infection, the person acquires chlamydia or gonorrhea and sexually transmitted disease, it is more likely for that infection to go to upper reproductive tract. Okay, so IUD itself does not cause PID or infertility. It's a facilitator in infection state. Also, especially I have population here, and they are known to, they come to dysplasia clinic with abnormal pap smears. Things like lip procedures, right, where the cervix is excised, part of the cervix is excised because of abnormal pap can cause the stenosis of the cervix. So that can be a reason for infertility. So again, going over the history of cervical dysplasia is important. And again, to look at the vagina and vulva, are there any septums there, anything that can obstruct flow of the cycle or the ascending of sperm to the egg. Right, we look at the ovaries, are there any tumors, any diseases, folliculogenesis, which means, how many eggs actually does the woman predicted to have at her age. So look at that also. And I'll talk about the factors that affect the follicles, affect the ability to produce the eggs. Right, systemic disease, diabetes, renal failure. Sometimes I have the diabetic patients that come to me and the hemoglobin A1C is 8 or 9. And I tell them, that the first thing you need to do is really control the diabetes. First of all, it can be one of the factors that's causing infertility. And even if you become pregnant, right, you know that uncontrolled diabetes can cause the abnormalities in the fetus and increased risk of miscarriage. So it's very important that you actually tell them you have to take care of the health before trying even to get pregnant. And then when we look at women, we look at the physical exam. Again, BMI, palpate the thyroid gland, look at the breasts, is there any signs of androgen excess, and regularly do the abdominal pelvic exam as usual. Again, if we look at the etiology, I said that there are many associated factors, but these factors do not absolutely cause infertility. They can actually cause the subfertility or decrease the fertility, right? The fetus has 6 to 7 million follicles, okay? But when the female fetus is born, only 2 million oocytes survive. So some of the follicles, they actually undergo what we call atresia or death in utero. Okay? By the time of the puberty is reached, it's only 300 to 500,000. And through the lifetime, only 500 follicles ovulate. Okay, so you can say that we have 500 chances to become pregnant. Approximately 500 chances to become pregnant throughout the lifetime, throughout the reproductive age. Again, age goes up, the fertility goes up. And it is irrespective of the career choices, irrespective of any other factors. It's just very clear association with the age. You see that what the baseline fertility rates are. And there are some percentages there. Again, late 30s, it's a 90% of fertility rate. At age 45 to 49, it comes down to 14%. Usually after age 35 until age 40, the fertility declines slowly, you'll see by the graph, right? And then after age 40, there is a sharp decline, okay? So if somebody is 39 and 40-year-old, you really want to be aggressive and, start treatment as fast as possible. Again, these are just some statistics in terms of IVF, what's the fecundity, respective of age, and a few slides talk about the age, but I'll go a little bit faster because pretty much the message is the same, that miscarriage rate goes up and fertility goes down as the age goes up. Now, PID, right, pelvic inflammatory disease, very important, especially when we see the young population, sexually active population, to tell them you have to use the contraception. Birth control pill protects from pregnancy, does not protect from STDs. Especially, you look at the statistics. After one episode of PID, incidence of infertility is 11%. And you see how it goes up after 3%, right? Half of these women who had 3 episodes of PID end up to be infertile. And unfortunately, chlamydia is a silent enemy, okay, because half of the women who had chlamydia don't even know that they ever had chlamydia. That's why we as OBGYN usually have very low tolerance in terms of treating and sometimes even empirically or over-treating patients because we know what the impact might be. So it's always better to treat if there is a suspicion but not a clear diagnosis than to not to treat. Now, surgical repair of tubal damage. There are 2 types of population that have tubal damage. One, if it's damage from the infection, such as chlamydia, and the second population who tied their tubes, they didn't want kids anymore, and then they come back to me, and life is long, and sometimes young patients don't realize they have 2-3 kids, and they are already 29-year-old, and they say, I'm done, okay? And unfortunately, things change. Something happens to the partner. We change as women as we go through the life, and then suddenly we end up wanting more children, and tubes are tied. So always important to counsel young patients not to rush to tie the tubes, okay? Because then they come to my clinic and or when I'm there, residents are doing the tubal ligation, and I see the age 29, 30, I say, please take as little as possible.
Yes. I have one more question, since your profession. What's the oldest you've seen a woman pregnant and delivered?
Right. I know that in news it was somebody who was 65-year-old, right?
Yeah.
And that's why I get sometimes patients that come in their 49, 50s, and they, but there was a woman who was pregnant at 65. Okay? I don't know how she got pregnant. But
it's kind of hard.
Right. Okay. Generally, what happens, it's not only getting pregnant, but also keeping the pregnancy and also delivering a healthy child. Okay? So you have to keep in mind. If the chance of having the baby with the Down syndrome is, 50%, I don't think it's wise, right? It's age close to 50, even if you can, to have a child. There are a lot of economical and social, and how are you going to raise the child, and how much life expectancy we have as parents to support our children, to give everything to them that we can give. So there is a lot of thought into it. Right? But generally, fertility clinics, we see patients up to 45, reasonable age, right, 45. And we can test the fertility by few tests to say, they don't say for sure, but they give a prediction what is the likelihood of success of the IVF.
Interestingly, a few of my patients had this overwhelming desire to have a child. And they were 49, 50, and they went through an enormous toll physically from hormonal supplements and everything, and their lives were practically ruined. I mean, they became pregnant, they had children, but the toll was unbelievable, psychologically and physically.
Absolutely. Yeah, many times, people don't think what is coming down the line, and it's difficult to predict everything. At that point, they want the child, so this is the priority. And then what happens after that, I guess it's a destiny. And again, the rates of are very different. If somebody gets pregnant, if they come and I try to open the tubes that are diseased, okay, versus I try to open the tubes that were just simply tied, but they were healthy. Okay, so the chances of having ectopic pregnancy is much higher if the tube was diseased versus it was healthy and it was simply tied. And I just want to say, at Nassau Medical Center, I'm proud because I'm one of the very few specialists who actually does the laparoscopic tubulary anastomosis. So it's, I have an interesting population. Frequency of intercourse also. A lot of times patients ask how often, and sometimes I see this male and they're sitting and they're quiet. I know the wives are killing them with having intercourse every day. You really have to explain what is the fertility window, what's the most likely chance of being pregnant, right? And I'll talk about that. This is just the menstrual cycle. Every textbook has this picture, what happens during the menstrual cycle. And we see in the middle, somewhere in the middle, there is an ovulation. Okay, so it's very important that we have, patients have intercourse around this time. Now, how do we predict when does the ovulation happen? And there are a few tests. Again, fertility window is about 6-day interval. It's ending on the day of ovulation. And the tests that predict, you'll be surprised. The best predictor is the cervical mucus. Okay, so many times patients can tell themselves when the mucus becomes stretchy and it's permeable to the sperm. This is when the patient usually ovulates. And by the way, it's much better predictor than any LH kit or any blood test that we do. Okay. But there are also, in the pharmacy, there are some LH kits that can be tested, and usually ovulation happens within 24 to 36 hours if it's positive. Also there are more invasive tests, such as endometrial biopsy, that can have a suggestion of the ovulation. We can follow by the ultrasound. So you see, once the patient comes to me, it becomes more and more expensive. Okay. Again, change of cervical mucus is very important, and it's cost-free pretty much. Again, they usually ask, can we use the lubricants? And there are different types of lubricants. And interesting that saliva is not good for sperm. It actually kills the sperm. Okay, so oral sex is not good to become pregnant. Not because it's oral, but because it's but there are some lubricants such as canola oil and mineral oil or pre-seed. Okay, patients can use those types of. KY jelly is not a lubricant for somebody who's like. Can you try it? And again, we spoke about environmental factors that affect fertility. Smoking, very important. People who smoke, female patients who smoke, they go to menopause earlier. Okay, so it's toxic to all sides, unfortunately. So you have to counsel patients, stop smoking if you want to get pregnant. Okay. Alcohol also, but it has to be 5 or more drinks per day. It's an association, okay, not the absolute risk factor. Caffeine, the studies show more than 5 cups of coffee. I don't know where they found the population that they tested, but this is the statistics of the modifier. A lot of coffee can affect. Generally, 1 or 2 cups is not going to affect. Okay, again, environmental factors might have some implication with the fertility. This is a very interesting slide and very shocking slide. This one. This shows the obesity in the United States. Okay, and if you look, this color is more than BMI more than 30. Okay, so now look at the states. The population has BMI more than 30, 25, 20, and 50. Okay, so this is And if actually it's interesting, if you go to this website, to the CDC website, and you see over years how the colors been changing, okay? Initially, the United States was all white, then became lightly blue, dark blue, and now look where we are in terms of obesity. Okay? And white is important in terms of fertility because obese patients do not ovulate on a regular basis, right? They are amenorrheic, aside from other health risks. And also on the other hand, we have the media that shows all the skinny girls, so this, another, right, to lose weight, lose weight, lose weight. So many times teenagers we see that are actually below the weight that they can menstruate also. So extremes are not good enough. Okay. Polycystic ovaries also, right, very common disease. And the definition of polycystic ovaries is it's 2 out of 3, which is presence of follicles, multiple follicles on both sides, generally more than 12 on each side. The hyperandrogenemia, or the clinical manifestation of hyperandrogenemia, such as hirsutism, acne, and irregular periods. So there are 2 out of 3 you can pretty much diagnose the PCOS. There was a big attention paid to insulin resistance as a part of the polycystic ovary syndrome, and it's plus minus. You don't have to be insulin resistant to have the diagnosis of PCOS, and you don't have to be obese. There are lean polycystic ovary patients. Okay, so obesity is not the diagnosis for PCOS as well. Okay, and here I'm showing this acanthosis nigricans, right, which is sign of insulin resistance. So many times I look at the back. Some patients come to me, doctor, I have this darkening of the skin folds, and I'm washing and I'm scrubbing, they're not going away. So this is because the melanocytes, they actually respond to the insulin. They have insulin receptors, so this is the reason of darkening of the skin folds, right? And there are different extents to which the polycystic ovarian syndrome can go. It's not only infertility, not only irregular periods, but these patients are obese, so they are at risk of cardiovascular disease. They are at risk of endometrial cancer, okay? So in GYN, we have this kind of cutoff, arbitrary cutoff, that if there are irregular periods and patient is more than 35-year-old, we have to do endometrial biopsy to make sure they don't have endometrial cancer. It's not true for PCOS patients. If the patient is 19 or 20-year-old and she menstruates once a year, you have to do endometrial biopsy. We have 19 and 20-year-olds with endometrial cancer with this pathology. So very important to have a broader look or broader perspective on this disease than just infertility or irregular periods. Okay. Elevated mercury levels have in some studies show some association with abnormal fetal development. Folic acid, very important. If we see patients, or if you in your practices see patients that want to get pregnant, just prescribe them prenatal vitamins. It's very important to start them on prenatal vitamins before they get pregnant. It tends to decrease the incidence of neural puberty. Now, this is just a relative frequency of different diseases, how they are related to infertility. You see the male factor is very high also, right? Okay. Now, the diagnostic evaluation, everything that we suspect is wrong, we're going to test it, of course. We're going to test the sperm. We're going to test whether the patient ovulates or not. The cervical factor, uterine factor, there are a few x-rays like hysterosalpingogram or pelvic sonogram that's done to rule out uterine abnormalities or tubal abnormalities. Endometriosis also is another major disease that has association with infertility. Okay. There are different ways to test the sperm, some strict, some not strict. I'm not going to go into the specifics of this evaluation. Okay. Again, assessment of ovulation, I mentioned, right? It's a cervical mucus, some blood tests, endometrial biopsy, including whether the patient ovulates or not. There is a so-called luteal phase defect, which many people think it's not a true diagnosis, but most of the fertility physicians are going to put the patients on the supplemental progesterone. Because if the egg, even if the patient ovulates, but the egg is not a good quality, does not produce enough progesterone, and we need progesterone to support the pregnancy, then we give progesterone, either in the form of tablets or vaginal gel and so forth, to support. But we don't know if it's an artificial support, if it really does do, but it's always better to give than not to give, so give progesterone. Now, I mentioned about assessing of ovulation reserve, right? Somebody around age 40 comes to me and says, what are my chances? Usually test their FSH level at the beginning of the cycle, and there are certain cutoffs that tell me that ovaries might be doing well or not well. Uterine factor, and I know that you asked me about the fibroids, to have a little attention, right? Little attention to the uterine fibroids, and I put a couple slides. Because they are very common, okay, and they are especially common, we know that in African American population rather than the white population. Very common problem. Not everybody is symptomatic, and not all the fibroids are causing the problems. The most common, yes please?
What is that? That's the fibroid?
Yeah.
That's the uterus with the fibroid?
Yeah, I tried to put the other picture.
That's the uterus with the fibroids.
It's uterus with the fibroids, so it's pretty much uterus that's cut in half, and there are some fibroids inside and outside.
That's not a real, that's something they made. That's not really for somebody's body, right?
It is somebody's body.
Somebody had that many fibroids
Yes.
all over
Yes.
and inside?
Yes. This is not the biggest. If you're impressed by that, I'll send you another picture. This usually comes up from the vagina, from the laparoscopy.
I'm sorry, the two things on top.
Yes. These are fibroids too.
Those are fibroids.
That's fibroid?
Everything is a fibroid.
All those is fibroids. Except the uterus and the surface there, I see that.
So you see there are different types of fibroids. So question is, are fibroids associated with infertility, right? Because they're, thank you. I asked to show me when I'm going over 30 minutes, so another 5 minutes. Thank you. There are different types of fibroids are associated with fertility or not associated. So if you have a fibroid which is inside of the cavity here, and even though the patient becomes pregnant, but the implantation happens over the fibroid, then the miscarriage can happen. So those types of patients, usually we advise to take fibroids out before they try to get pregnant. They are called the submucous fibroid. There are these fibroids, they're called subserosal. See, they're very far from where the baby is supposed to be. So generally, they don't have an influence. Now, if there is a fibroid that's here, and usually fallopian tubes come out of the uterus from here. So you see this fibroid is actually obstructing the fallopian tube. So there is no way the sperm is going to push this fibroid, right, to give him away. So these fibroids need to come out also. Okay?
From a young person, that's great.
That's wild.
Yes, you had a question? Yes.
Oh,
Oh,
okay.
I thought you were raising it. Okay.
Yeah.
So again,
Yeah.
oh, you do, okay. So.
Yeah, okay. If you're under 39 and you've been diagnosed with being infertile, should you get a second opinion?
Usually, every time you are uncomfortable with the diagnosis and you have questions, absolutely you should get a second opinion.
And what's the most accurate test? The most
In terms of what?
fertility?
There are different tests that test different problems. So each test has its own, accuracy. There is no one test that will tell you whether it's accurate or not. So it's not a polar magician that will look and say, okay, you can have baby or not. Now, intramural, which means fibroids that are here in the muscle, right? You see they're also away from the cavity. They are not quite out, so do they have any impact on fertility? So many times patients with fibroids, with this type of fibroids come. So uterus is actually big, it's full of fibroids, none of them are inside of the cavity. So what should we do? Should we take them out or don't take them out?
Don't take them out.
Huh? Don't take them out.
Depends on the system.
Don't take them out.
Yes, most of the time, also depends. Sometimes you have a big fibroid here, so when the cervix is dilating, it might obstruct the delivery. So then you go by very, very individual basis. But generally, the size of the fibroid, of intramural fibroid, is not an indication for surgery before attempting pregnancy. Okay? Now, if somebody is infertile with fibroids, do we take fibroids out to increase the fertility? And the studies are controversial. First suggestion is to test everything possible, and if everything is negative and patient is still unable to get pregnant, in those cases, some studies show that maybe myomectomy can slightly increase the fertility chance, okay? So it's not no is not an absolute answer. Some studies show that maybe you can enhance fertility with myomectomy also. But sometimes you remove fibroids and you cause adhesions in the pelvis. So you have to look at the other side also, okay? And again, different tests that can diagnose fibroids or uterine abnormalities. One of them is sonohysterogram, okay? It's very non-invasive, very easy test. You put little fluid inside of the cavity, you see if it's a polyp or fibroid. Polyps also can be associated with miscarriages, so that's why they're also, we encourage patients to take them out before attending the clinics. Okay? And I spoke about PID and endometriosis as factors with infertility. And I'm to my last slide, I believe. Unexplained infertility. No matter what we do sometimes, no matter what test we perform, we still cannot find the reason, okay? About 10% of infertility is unexplained. And then we empirically treat the patients, okay? I just want to thank you for this. And I hope healthy children. Thank you.
Do you have a website?
I mean, it's seen on YouTube, but I always put it when I get examined. How does a doctor, how do you, read the category. When you're in med school, do you have a plastic, like a dog, how do you clamp the woman for the examination or your spectrum? Or is it done by the plastic or with models? Or,
How you learn to do
yeah, how you learn? Have you not been looking down there, but you know?
I'll tell you how I learned. My father was OBGYN, okay? And I was in high school when he took me, and it was in Russia. So if something I say here probably doesn't happen right nowadays, but before, he would put me behind when he was doing a portion of procedure and ask me, Maggie, can you read a poem to the nurses? And I would stand there as a 5-year-old child and read poems.
Nice.
And I'm just saying there are different experiences. But generally, when we go to medical school, it also depends. There are simulation labs. Right now they're big. So you actually learn on the medicals different techniques.
I was wondering how to
Yeah, we actually have standardized patients, which are people that are hired to be patients, and they teach the medical student how to do the exam properly. They'll actually point down there with little Q-tips. Yeah, so they're not learning on the patients that they see. They learn on either mannequin and then the standardized patient person.
Education came a long way to actually answer your concerns, but this is the answer, exactly.
We have other speakers coming, and so we ran a little bit late.
Sure. If anybody has any questions, I'll be
patient. Really. Thank you. Thank you. You're an excellent speaker. Thank you so much.
Thank you.